and I'm here to welcome you to our live panel simulcast called Changing the Game, Embrace New Technology to Manage Assets. So not only do we have all of you here today, we're also broadcasting this panel live on the internet, so welcome to our online audience as well. Today's panel discussion, which is sponsored by Boundtree Medical, will cover the benefits of implementing leading-edge technology solutions to manage assets, to improve quality of care, and the bottom line. We have panelists from private ambulance companies and public municipal EMS agencies, as well as a noted medical expert to provide peer-to-peer advice and share how they changed the game for their organizations by embracing new technology to manage assets. So just a few housekeeping notes before we get started for our online audience. If you have questions during the webcast, click on the Q&A widget at the bottom of your console and submit your question at that time. We'll answer questions from both our online and our live audience at the Q&A portion at the end of the webcast. And if you have any technical difficulty, click on the Help widget with the question mark on it, or just type your issue into the Q&A widget. A member of our support team will work with you to resolve the issue. This webcast will be archived at gems.com/webcasts within 48 hours, so you can view it again and share it with your colleagues. And I'd like to thank again our sponsor, Boundtree Medical, for supporting this webcast. So before we begin the discussion, I'd like to introduce our moderator, Jonathan Washko. Jonathan Washko is the Assistant Vice President for the Center of Emergency Medical Services with North Shore Long Island Jewish Health System in New York City and Long Island, New York. He's active in numerous industry committees with the AAA and NEMSAC, sits on the editorial board with GEMS, and consults with organizations on an international basis on organizational improvement. He started in the EMS industry in 1986 and has held various progressive leadership positions at local, regional, and corporate levels with small, medium, and large-size EMS agencies. He's considered the leading industry expert on EMS system design, system status management, and high-performance EMS concepts. And with that, John, I will turn it over to you.
Thank you, Sarah, and thank you to Boundtree for hosting this great lunch this afternoon, and welcome everyone. We'd like to get started today by talking about how do we change the game when it comes to supply and logistics, and using technology to do that. And Boundtree and GEMS have put together a survey, and we'll go over that in a little bit, of the industry to find out what kind of problems are we having out there, what are the issues, and then brought together a panel of experts really that I guess each in their unique way have different perspectives of how to look at this problem and how to solve this problem, and then how to use technology in order to solve that problem. So there's a little bit of our guest today, myself. Like Sarah said, I actually work for Northwell Health. We used to be North Shore LIJ. 30 years in the industry, and a little bit about my background to this particular issue is one of the things that I guess I've had the pleasure of in my career is to see probably well over 100 different EMS systems, probably well over that now, around the globe, and see EMS organizations at their best. I've seen them at their worst, and I've seen them kind of in between. And I pick up, every place I have the opportunity to go and see, I always pick up best practices or nuances associated with how organizations do things. And a couple of years ago, I wrote an article in GEMS associated with some of these concepts, supply and logistics and speed loading and centralized deployment and standardization. So that's one of the reasons why I was asked to speak today and to moderate this panel is from that background. I'm going to go and kind of allow the panel to introduce themselves, as well as from a resume perspective, why are they here representing for this particular topic. And we have a nice, I would say, array of the industry cross-sections here. We have not-for-profit, hospital-based EMS service. We have a fire service medical director. We have a for-profit provider, and then we have an EMS chief with a fire service. So nice cross-section. Dr. Augustine, I'm going to ask you to introduce yourself and tell us a little bit more about your background. And I understand understand you have a really significant passion associated with a very important issue to all of us with drug shortages. So why don't you explain that to us a little bit?
So I'm Jim Augustine. I'm an emergency physician and have been involved in fire EMS since my medical school days. So 35 years of working in the streets. My background is in Ohio and Atlanta, Georgia, and in the Naples, Florida area. I'm here because I'm the one most angry about drug shortages in the country. We began this issue in 2010, working in the emergency department and working in the streets. You want to reach in the bag and get something, and someone would say that that's not available, or it's not in the bag, or it's not in the place that it's been in for 20 years in the bag, and it's been repackaged or put into an entirely different container. In 2011, we really began to note the shortage in all of the markets where I work, and we began pleading with the federal government to take some action in regard to the drug shortage and the safety issues that it brings up for patients and for our providers. And so I am here to talk a lot about asset management when it comes to drugs and the safety and process and staff satisfaction issues associated with it. Thank you.
Yeah, thank you. Very important issues. I know the survey teased out, I think it's one of the top concerns when we discuss supply and logistic issues in the industry is the drug shortage and the costs and all the challenges associated with it that come with it, with hoarding and some of the other things that happen. So I'm definitely looking forward to hearing your input and feedback. Sean, why don't you tell us a little bit about your perspective on things?
Thank you. Patrick Sean Tyler, President and Chief Operating Officer for Fallon Ambulance Service up in the Boston market. It's interesting is that as you hear Dr. Augustine talk about drug shortages, supply shortages, things that are triggers and levers in the private industry specifically deal with what others would consider lean process. As we kind of talk about EMS 3.0 at the AAA conference here, you realize that one of the key aims of the triple aim is reducing total medical expense, and I look at from an ambulance service kind of as a living, breathing being, so to speak, and how does one reduce total cost of operation to compel better drivers for patient care. As a 20-year paramedic in the space and as a career student with a DBA and a concentration in organizational behavior, it came to me that there is a lot of innovation that can be used with successful management of the simple elements of supply. Does every crew have a consistent application, use, and access to the same supplies in the same place without fear of missing, without fear of expiration? Do ambulance services and agencies who are regulated, which we all are, do we ensure that we have the right stock in the right place at the right time, no expiration issues, availability of that stock? We can manage beyond just-in-time, but at that periphery of just-in-time. So as I look at the asset management, whether it's durables, whether it's replaceables, or whether it's other opportunities, I see technological innovation as kind of driving better patient outcomes by making ambulance services more sustainable through reducing costs.
Great. Thank you very much. Chief Baker.
Yes, sir.
Tulsa Fire Department.
Greetings.
Greetings.
Is this on? I may have to talk to you. So, there we go. Michael Baker. I'm the Chief of EMS for Tulsa Fire. I've been in that position for, I don't know, 8 years or so, which is kind of an anomaly in the fire service, being an EMS guy. 22 and a half years on Tulsa Fire, 27 in EMS in general. So I took a little bit different approach, and I'm the ultimate end user in the public safety side, especially on the government side, in that I can't just create positions to manage supplies and equipment. I have a limited supply and equipment budget, and I have 30 distributed stations across 192 square miles of territory. And the supply monster was just literally eating our operations. When I took this job, the director of operations at the time for the EMS authority, the first words out of his mouth was, "You have to keep your fire crews from stripping my ambulances." And I said, oh, okay, great, good to see you as well. Thank you for the welcome. And so we just found that we were basically part of that bottom line for the authority, which was the budget amount of stuff that they lost to the fire service. And we really didn't want to be that way. We found that when we analyzed the system, we had a lot of inconsistencies. We weren't compliant with rig check. We weren't compliant with state regulation. And one of the stories I like to tell is this $45 oxygen wrench, which has to be driven 30 minutes across town. I'm carrying a dollar item across town. I've got staff time for that. And it was just eating up efficiencies within our operations. And then last but not least is the fact of strategic, operational hoarding, where I think it's, I don't like to use the word hoarding because that says that you have some emotional attachment to the items. But I think that we tend to be, as a profession, especially in the fire service, a little bit redundant. If you break a section of hose, you pull 2 hoses sections to replace it. So why not take 2 bandages, 2 cric kits, 2 halo chest seals, et cetera? And it was just killing us. So since I can't apply people and have oversight that way, I apply technology. And we've been strong users of all kinds of components that we're going to talk about today.
Great. Thank you. And Chief Baker and I actually go way back to my very first job in a high-performance EMS system in Tulsa. So it's good to see you again and good to work with you again. So let's talk a little bit more about the actual survey, and then we're going to use the survey results to kind of drive the conversation. And so the survey was conducted by GEMS, and just some quick facts about the survey, that there were no significant differences in the issues identified between private and municipal agencies, which was very interesting. There's definite challenges in managing inventory as identified by the industry. Many organizations don't have a system or a process or a formalized system or process in place for managing a lot of their assets, and I see this oftentimes in some of my improvement work around the country. It's kind of it's done by look and feel. It's done by it's the supervisor's job today, and there's just no real systemized approach to it. And as many of you have probably heard in some of the things that I speak on, if you can't measure it, you can't manage it. And the fact that now we have systems available to us in the industry to collect data as well as manage these systems, we can finally start to manage some of these things. And so it's a great time in our industry for these types of issues. And then finally, the issue of expired meds and how do we manage medications that are expiring. The cost of medications are going up. Our reimbursement is not tied, to expense directly, unfortunately, and so we end up having to take on the burden. So you have to figure out, while the AAA is trying to figure out payment reform, we unfortunately are put in the situation of how to figure out how to do it better, faster, and cheaper, and that's where technology can help us hopefully take advantage of that. So here's a quick overview of the survey results from a demographic standpoint. Again, the type of organization and job functions. There were a total of 327 responses that GEMS sent out in July of 2017. And this was sent out to EMS leaders within the GEMS audience. And like I said, we had a nice mix of the different service types represented in the survey. So we're going to get into the specifics related to the survey and the results and share them with you. And I believe there's some handouts also in front of you that also go over some of the results that were found. But we're going to lead off with what are your inventory management pain points. And you can see there's the different type of services are represented by the different colored bars. And then the questions associated with the responses are on the left side there. We talk about expired meds, definitely a huge concern. Hoarding of inventory, like we talked about, which absolutely happens. Time and labor spent on inventory accounting and how much time that it takes, and that's a huge challenge, as well as lack of inventory availability. So again, if you're not measuring it, you're not managing it, especially if you're doing just-in-time ordering and you're not warehousing a significant amount of medications or a significant amount of supplies because you can't afford it. Managing that is an important piece, and then others. So Chief Baker, I think you had mentioned you'd like to comment on this or kind of lead us off.
Sure.
Much like I spoke about in the introduction, a lot of the, at least the top three issues are challenges that we face within Tulsa Fire as well. So expired pharmaceuticals, we offset that with the Operative IQ system rig check component, where we can actually have the fire crews verify expiration dates at their rig check each day. That has saved us. We virtually eliminated the rig check and expired medication issue. State level inspections have revealed that we don't have any concerns on equipment that is in that system, and so it's been a very beneficial process for us just to be able to have that everyday accountability. And we can also go in and understand, much like Dr. Augustine is going to talk about, when you're measuring medication shortages and you're looking for your inventory. For us, we had our old system to determine what we had in the field that was going to expire was a phone tree, and making calls and say, hey, tell me what you've got on your truck. And now we can pull it up in real time and look what's out there and understand what we have to order and not. Secondly, hoarding. We went from a system of 30 supply lockers that were checked every month by and maintained by a fire crew. I don't think I have to say any more about that right off the bat, but we switched to a system of 5 vending machines in a hub and spoke kind of format. So they now go to that. I have real-time business intelligence about what the contents are, what the expiration dates of the items are within the machine, and then what the inventory levels are. So now, between knowing what's on the truck and knowing what's in my field inventory, we were able to demonstrate about $25,000 worth of savings within the first 6 months by pulling those extra supplies out. And if you need triangular bandages, let me know. I have masses of them, because evidently we felt like we needed them. And then last but not least, I talked a little bit about labor saving, traveling into the time. So we put the highest utilized items within the vending systems. They have a one-for-one exchange with the transport crew of items used, but we found that we solved the majority of the problems by allowing folks to travel to a vending machine, pull out the high utilized item, and get it back in stock. So 24/7, 365, they don't have to wait for someone from a central warehouse to deliver to the field. And for us, it's been very productive.
On the, I'm curious on your inventory and your restocking. So you're saying pretty much in real time what you have on hand within each of the vending machines. How do you go and then restock those vending machines? What's your process behind that? If you'd share that with us a little bit.
So what we've been able to do is maintain a small central warehouse where we keep less materials now, because we know that we have basically small warehouses distributed throughout the city. So what we do is we just watch that. I get reports. My one EMS supply person gets reports, and we know exactly where we're at, and we begin to pull items, and then we just basically put them out of a rack system into bins that are labeled and colored for the area, and then so all we have to do is replenish exactly what is needed in that machine, and so it's cut the labor costs way down.
Yeah, and so you're doing it just in time, on demand, or do you have like a set schedule once a week you're restocking, or how do you manage that?
It is. Sorry, I didn't answer your original question. It is about every 2 weeks.
Wow, that's great. That's amazing. So that definitely can help lower your labor costs. Like you said, you have one person, right? Just dedicated for restocking, which the labor savings right there alone is tremendous. Dr. Augustine, I know you had mentioned on this particular slide the drug shortage issues that people, so do you want to maybe talk about some of those?
So again, I work in very different kinds of systems, but in Dayton, Ohio, since the late 1970s, there's been a regional EMS council, a regional drug box program, regional protocols, regional stocking that is handled by the hospitals. The same drug box is used in primary care physician offices, specialty physician offices, and then all the crews have to do is go in and get a new drug box. There's cutouts for each of the drugs that are needed, and a regional program of not letting things expire by pushing them to the places where they're more likely to be used. Many of you grew up in the same systems I did. Glucagon, the cost of wasted glucagon was more than all of the other medicines that we used, right? But we had to have glucagon available, ready for our diabetic patients that we couldn't get IVs on. Fast forward to 2011, where we had so little mag sulfate in the community that we had to distribute it amongst the hospitals and pre-hospital care, because a woman who's having an eclamptic seizure in crisis has to have that drug, and there really is no replacement for it. And so we had a regional supply available on one vehicle, and wherever that might be needed, you're moving a vehicle with magnesium and water to that patient, and then offering up supplies to the pre-hospital environment and the emergency department, and then into the labor and delivery unit, et cetera. This is crazy times. Salt water, sugar water, baking soda and water, and we're short on, and having to move not only through stations, but through an entire region to be able to get to the supplies that we need in the frontline vehicles as well as in the hospitals and emergency departments. Boundtree was nice enough beginning in 2011 to give us the shortage list, and we send that out, weekly or monthly to involved agencies. We can then try to plan ahead. We took every one of the medicines in the emergency environment, came up with the alternatives that were available, knew where our critical shortages could be, like mag sulfate, which simply doesn't have another replacement available for it. And then watched as costs went up on some of these medicines, availability went to zero. This again is a national manufacturing issue and not a regional or a distributor issue, and have had to develop the solutions that address each one of these areas. There are systems that allow you not to hoard, and that is simply when there's nothing available. You can't hoard anything. But this is really difficult. I'm going to get back to the people again who are delivering care. We've had a box that had a exact same setup, and at 2 o'clock in the morning, people knew they could reach into this part of the box and pull out Epi or pull out Narcan or pull out another needed medicine. And this is all destroyed now because we don't have the same sizes available. In some cases, we have different medicines. We've had to color code things. We've had to develop just-in-time education. And people are nervous about pulling medicines out now. We've had mistakes made. Adrenaline and adenosine look very similar when you don't have your glasses on. It's 3 in the morning and you're reaching in. And can you imagine a patient who needs adrenaline getting adenosine, or a patient needs adenosine getting adrenaline? And so we worry about our people, and then, of course, about the patients that we take care of. And all of these things relate to good staff confidence in what they're doing, and the availability of educational programs to get them just-in-time education, and about the patients and what they're getting or not getting as a result of it.
Yeah, thanks. I mean, it's a huge issue. I mean, I'm a big proponent of standardization, and by destandardizing, it can create all kinds of challenges, quality issues, as you were suggesting, provider issues, other things too. I remember hearing, and I'm sure it's even still happening today, where EMS agencies were having to turn to compounding pharmacies, local compounding pharmacies, in order to make the drugs that they needed. And it's just been very interesting to watch what's been happening, and we'll talk more about some of the reasoning behind it as we move forward.
Sean can probably tell us about compounding pharmacies from what happened in his world.
Yep.
Full disclaimer: Massachusetts doesn't actually acknowledge any of that.
Okay, very good.
So let's see. So for our next question, what is your estimate for wasted inventory each year? Significant portion of folks said about basically 25% of your inventory costs are wasted. I have a feeling, Chief Baker, you probably disagree with that. You'd probably say maybe even higher, right? Based upon when you look at the cost of labor, the cost of storage, we're not just talking about the stuff that gets thrown away or donated to whatever, the training department because it's expired out, or it's got so much diesel soot on it from sitting in the truck for 10 years. It's those kind of challenges. So why don't you give us some thoughts here?
Well, we've moved from the high side to the low side with everybody else down around the less than 25%. My basic pattern was to buy, store, and trash. That was pretty much the cycle. So we held that we'd made a purchase, we'd hold it in inventory until it expired, and then we'd throw it away. And it doesn't contribute to an overall system benefit when we're not using it. And I blame a little bit on the ability for a system like mine, where we have a mix of we do ALS and BLS first response. So I'm having to cover two different I have to have a massive amount of inventory of small volumes, and when you have to buy large volume, items, then you end up wasting a little bit, or it ends up naturally expiring. And so improving those little sections helped move us from the high waste over. And I'm telling you, that accountability at the individual level and the tracking and the intelligence side kept us out of that waste. And what we didn't know what we didn't know. And so until we had that information, we realized that all of a sudden we were supplying every police officer in our community with halo chest seals and cat tourniquets. And I kept wondering where all these patients were, because my QI was not demonstrating that I needed crike kits out there in the field all day, but yet I'm giving away a lot of them. And so we moved out of that accountability, and that's really what we found when I don't have direct, not everyone's coming to one central location. I have to trust that there's some oversight in the field, and that has, by reducing that and reducing the opportunity for waste, we've been able to really move ourselves to the good side and reduce that to near zero, really.
That's great. Yeah, that's one of the challenges, I mean, that a lot of people don't talk about, but just the inventory that sometimes, unfortunately, walks out the door, whether it's supplementing someone's own personal response bag or potentially another agency. I remember, I think it was Tulsa, when you and I were working together, it was always the case of the disappearing backboards. And we were buying massive inventories of backboards back when, we boarded everyone. And,
we protocoled those out now, so you're good.
Yeah, now we're good, right? Dr. Augustine, do you have anything on this issue?
Yeah, I have strong feelings here. We have expiration dates that are posted by manufacturers. And for many years, the hospital pharmacists have led the charge to say that manufacturers' posted expiration dates are clearly understated by years and years, and that these drugs remain fully potent and not compromised in any way for years after they've been past their expiration dates. The drug manufacturers don't recognize that and post shorter expiration dates. Point two, we need our entire industry to understand perfectly that the issue here is a manufacturing issue, and that if bicarb is not been manufactured for a year or 18 months, that if somebody all of a sudden has some bicarb, it means they found a box somewhere in the back of the warehouse. They're going to sell it at full price to you, but the expiration date is in 30 days. And so we've had unscrupulous distributors who've been selling full-price stuff that has a very short shelf life. We've had to go state by state to the pharmacy boards and the EMS boards and talk about the use of expired medicines. The manufacturers recently gave up on 4 medicines that allowed another year past their posted expiration date. You guys were probably both dealing with just-in-time education programs about why we're using our epinephrine a year beyond its expiration date. So we've had to go through all of these dances with this issue, with, again, our street-level personnel, our logistics personnel, our emergency department personnel, all the way through the system, when really the basic medicines we use are probably safe for many years. And then this problem we really have to break out by particular kinds of drugs. And when nitroglycerin is posted, that's the one drug that beyond its expiration date almost certainly is not viable. But many of the others are. And many of the others, we again worry about wasted inventory. Our EPI moves so quickly through the system now, we never have an inventory wastage program associated with it. But other drugs, and I'll use glucagon as one, it's a biologic, it's very expensive, we hate to waste it, and it's almost gotten cost prohibitive for us to keep it in the trucks.
So I'm curious, for those of you that are using some of the technology, are you able to do any kind of load balancing? So in other words, look at where there's high volume or high utilization of one type of drug or device or something like that, and move it from maybe a lower area and do some redistribution?
Very clearly we can do that within the system, and we also do it with the hospitals when it doesn't come to controlled substances. You've got to be real careful to fulfill your regulatory requirements, but yes, that's an option.
Yep. So that is a solution that I've also seen people doing out there, some of that. So.
Yep.
So next question, how do you manage your inventory levels? Like I said, I've seen this all over the board, everything from, the look and feel. Well, let me go look in the warehouse and feel in the box. Yep, there's still stuff there. That's one mechanism I've seen, to spreadsheets, to, very sophisticated online systems that I think some of you guys are using. Is there anything else, Mike, that you'd add, to the systems that you're using for managing your inventory levels? Or I know you had mentioned that you guys are able to kind of reduce your warehousing, your central warehousing, and so therefore I assume your costs of holding inventory. So maybe you could tell us a little bit about that.
Yes. So we've been able to right now, and we're probably living off of some of the non-medication items, but we've been able to. What we found is by knowing what the utilization is of the items, especially medications in the field, items that we were stocking, even in vending, because we know what the use is and who is taking the items from what company, what location. We can say, you know what, we're not using that. We don't need to keep that in vending. We don't need to keep that in the field. We can allow that to be distributed by EMS supervision or EMS staff. And so it goes back to having that the good data input and business intelligence that we get to be able to tell us when we need to shift. And so we've been able to change some items within vending and move to a system that is really informed, or maybe we do need something different out in the field. Additionally, I think just to kind of add on to what Dr. Augustine was talking about, one of the areas that I think is most important in the first response community is the management of temperature. So it's not just for us to preserve that expiration date is temperature management, and so a fire apparatus is not the best and most hospitable environment for medication climate control. So that was one of the first things that we had to do up front, was get those medications that we have within a climate and establish policies and practices for their safety and their long term. So I want to get the most out of that medication I can, and for the patient obviously quality, but it helps us with that expiration point as well. So there's a lot of little tricks that just once again it goes back to the intelligence that you get through utilization of software and data. Yep.
Well, I know it's listed here as one of the lowest utilized things, but I know that I think, Sean, you have a passion for this, the use of RFID. And I mean, I've dreamt for many, many years the time when an ambulance can pull up to a central bay and basically spit out, we're actually on their way for end of shift, right? Have a report automatically show up to the guys that pick and restock, saying this is what was used on the ambulance today, and let's go and restock it. And clearly RFID technology could potentially help us, going forward. Sean, do you have any comments on that?
Thank you. Thank you very much for that definite soft toss. With regards to RFID and the very principled component of the Internet of Things, or IoT, I think it becomes kind of this esoteric, really shapeless, amorphic piece when people think technology and RFID and logistics and support and stock. How do you make an ambulance into a smart ambulance? How do you actually make it such that your data, whether we use Operative IQ and we have a digital analog system of bins that we rotate and flush our stock through all of our ambulances. And tangibly, we've reduced our spend on durable equipment and disposables by 25% annually. With regards to RFID, again, as a paramedic, I look at it in kind of answering some of the drug box issues. Now, each system is different, and whether you have a homogenized system like Dr. Augustine just described in Ohio, or whether you have manual respects for crews like we have in Massachusetts, where crews go through and they check their drugs. From my vantage point, there are opportunities and there are solutions that exist that have smart drug boxes that do your check for you, centralized data into whether it's a rig check, an Operative IQ, or another solution that identifies when a medication went in a box, when a medication went out of a box, whether a controlled substance was touched, moved, and by whom and when. And now if you fast forward into the rest of your ambulance, whether the stretcher's going in and out, whether it's your scoop stretcher or your any other piece of equipment, there are opportunities to kind of identify, what is being used where and when and where was it left. And that is the beauty of RFID. And what I'm talking about isn't visionary. What I'm talking about are solutions that do exist today.
Yeah, no, that's great. I'm very much looking forward to as IoT comes out, and really the biggest challenge with RFID has really been the cost of the tag, right? And then also some of the technology, especially when you bundle things tightly together, is can the tags, there's been some issues with technology that I think have been slowly being overcome. and now can be of significant value. We've been Wi-Fi tagging, not RFID tagging, some of our larger assets like our monitors and things like that, so that if they do get left behind, there's a smart notification to someone that, hey guys, you left a $30,000 piece of equipment behind, you might want to go get it, kinds of things. And it does happen, believe it or not. We lost one that kind of pushed us in that direction. So the technology is really, I think, helping to improve and solve some of these problems. Sean, I know this was one of your slides that you wanted to chat on. So what is preventing you from pursuing a technology solution? Or what do you think for you, but also for the industry?
Oh, sure. So I think I kind of took the you as ubiquitous. You as in, hey, in the private ambulance industry, what would be one of the inhibitors or prohibitors for folks pursuing a technology solution? And I think, as I had alluded to earlier, it's really putting people's minds around that these are achievable solutions and the value that gets added. When you look at the value chain in the ambulance world, specifically on kind of managing your patients and the care that you provide, we're very quick to identify how effective we are at getting ambulances to request for service, how quickly we are, or functionally we are able to deliver life-saving treatments. But we don't necessarily focus on the in-between of getting the crew into the ambulance, getting the ambulance prepared to take care of a patient, and giving the crews the solutions. So one of the prohibitions is truly, one, in the marketplace, having solutions that truly answer the needs of the end users, the patients or the receivers of the stock and support, the crews who have to use it day in and day out, and then consequently is the services. You get a lot of kind of off-the-shelf, we think this is your problem, so we're going to solve that, but we don't necessarily have things that can indeed say, okay, in order to smartly manage assets, what does that mean for each individual EMS agency, public, private, third service, volunteer, nonprofit, whichever, what are those solutions? So when you see manufacturers today coming to the table as it relates to technology, you have bar scanners, you have low-level RFID, passive RFID, you may see some things with Wi-Fi enabled tagging, but you don't have one ubiquitous solution that actually manages that. So again, to inhibit the adoption there's not necessarily something that is going to be that uniformly available. In the vending machines, UCAPIT is a great solution in very many markets, and it's very successful. What is the solution in the drug box world? What's the solution in the durable equipment that we have in the back?
Yeah. So it also, I'm going to throw a couple of cents in on this one too. Throwing the MBA hat on or the business hat on here for a minute. There are innovative ways to look at financing, some of these systems. Because when you look at the respondents here, the number one issue is they don't have the budget for the capital. So, think outside of the box when it comes to these things. How can you turn capital into operating? Is often done many times. And whether you're working with an organization like Boundtree or others that are out there, don't be afraid to go and ask them, hey, we really want to leverage this system. We really want to use this. How can you help us? Help you, help us, or them, that type of thing. And you'll find if you ask the right questions, they're willing to work with you. So you can reduce the barriers of access or barriers of entry, on this technology. You just have to ask the question. So don't always think about the traditional ways that sometimes we get, boxed into. So who is accountable for managing inventory? Sean, this was one of yours as well.
Yep, no, I appreciate that. So in my service, we have a designated, kind of much like what Chief Baker was referencing, we have our supply guy or gal. We use, again, a digital analog solution using Operative IQ, where we do just-in-time ordering and we keep a small cache on scene for disasters. But very specifically, we want to be using a bin system to create a level of homogeneity between ALS and BLS ambulances. Doesn't matter if it's being picked up in the northern part of Boston or if it's being picked up on the South Shore. Every ambulance is configured just the same. So from a supply management vantage point, you have what the humans are responsible to do is ensure the safe delivery and recovery of unused and open bins, so to speak. Insofar as a function, it really is an executive function in managing logistics and those supports, because it is indeed a cost driver and it's an efficiency driver in our ability to provide patient care. So it has an executive sponsor to ensure that we're able to deliver, not just create functions, but we have ensure that we're actually able to drive a sustainable solution.
Yeah, I mean, did you have something to add?
Let's just go through the history again. The logistics person in your office used to be a fairly invisible type, and maybe good at accounting and maybe just good at looking at the bins. This person now has a central role, and especially related to medicines and other critical pieces and very expensive pieces of equipment. Logistics has moved up in the hierarchy significantly, and now has to be used not only for managing the inventory but planning and budgeting. And as the costs have ratcheted up very, very quickly, we're asking them to think ahead and then develop solutions. And again, for a lot of this, the larger we get to the potential set of solutions, and I say even at the regional level, where we're now dealing with, in my area of Ohio, Narcan is in short supply. When we get a bad fentanyl-contaminated load of drugs into the region, you run out of Narcan, and we're using larger and larger quantities of now an expensive medicine, and so you have to go to regional sharing systems to be able to get that, because the last thing we can afford is for the crews to be out and not have what they need. And I have been there, on the roof, out on the interstate, down in a hole, without enough medicine because our drug boxes are short, and that's one of the areas we cannot afford. And with logistics, they have to be tied enough into operations that they know what is it that we need to have, and potentially where we're real short, where would it be best placed? If you said the rigs are all supplied, but in some cases we're looking at the rigs that would be doing more peds and making sure that they have more peds drugs, or they're working in the elderly areas and the nursing home runs, and they need more of certain things. That's how the logistics person has moved up into the planning phases across a lot of our departments.
It's kind of like that's the informatics and analytics piece, and that's kind of the power of having some of that digital technology is anticipating, right, tying it to the types of patients that you deal with, such that you can have that equipment available when that equipment is needed, or at least pre-planned and anticipated.
Right. Well, and it also brings about, it's about situational awareness, right? And so data can drive situational awareness. But you bring up a very interesting point, which is, regionalized systems of care, right? And I think we're really starting to think more in terms of larger systems, and the ability to understand an inventory of, an EMS provider next to you or someone else that you could potentially swap with or work with. I mean, this cloud-based technology really could potentially open up opportunities for you allowing to see someone else, maybe have some transparency and and so now you know who to call versus, trying to go down other roads where you're sending out mass emails to everybody, screaming for help, right, kind of thing. So it's very interesting. Never thought through that, but there's clearly an opportunity there. That's great. So Chief Baker, how do you mentioned a little bit how you guys store your supplies. Why don't you go into a little more detail on that?
So once again, we have a central warehouse as well, and kind of our old school process was pull things, and we used a lot of T-shirt bags / whatever we could get, and we had a kind of everybody grabbed a pile of bags and distributed them on the way home at the end of the day to whatever station had a need, and that system, it was we just had stuff everywhere that was just unaccounted for and sitting. I mean, it would give me nightmares about the amount of expiration that was going on and the inefficiencies of that. And once we put a little bit of that on our EMS field supervision, and they felt, their complaints to me were they felt like that they were just these glorified delivery folks, and all they were doing is going around making rounds and never really actually supervising or, participating in the patient care experience. And so, we had to really go back and look at every component of the supply system or the process that we had. And we started fairly small. We started with our warehouse first to really kind of understand what we were utilizing there. We went to if you're familiar with an ABC type system where we prioritize where things are on shelves, we tried to kind of reorganize for that for efficiency. We also went to color-coded bins because I was often the person on the weekend that had to come in and get something, and I didn't like looking through all blue bins for one thing and looking at a small label. So we color-coded, and we put in some, really some, better processes to get those things and organized. And so just really a cleanup of that process. And I think it is kind of a conversation about storage, but the two best things that I ever bought in my EMS career is a vacuum sealer and a heat shrink sealer or a heat bag sealer. And now we make our own kits, and that helps with, so I can take, 10 4x4s and shrink them down to the size of a quarter or a half dollar. And for a staff vehicle that requires those to have them in inventory, that used to come back with a sopping wet bag and nasty, we just threw them all away. And now we've eliminated that. And so by packaging our own thing, making our own Narcan kits, our own Epi kits, allowing them to be we literally package Band-Aids in a vending kind of packaging. So that has allowed us to increase the durability of our consumables, and I really do think it has a lot to do with the storage. And so just by doing that, the crews tend to use it. We often insert protocol. So much like Dr. Augustine said, at 2 o'clock in the morning when you have your glasses on, you can clearly make sure that you're compliant. And so when we build a kit, we insert the protocol in there because I am dealing with a large volume of providers, many at different levels, and ALS and BLS, and I have to put it across all aspects. So having that clarification really has helped us as well. So I think that goes to a lot of the storage.
Yeah, that's great. The other thing too that I'll bring up is purpose-built workflows, right? And so we at Northwell just opened up a very large central deployment center, and the design around that, we didn't get to build the whole building, but we got to kind of design the workflow and have an automatic car wash system because the amount of time it takes for staff to wash a car is expensive, and we want to have it out there each time. And we use the idea of kind of the rental car return system where the ambulance pulls in, it gets washed, and then goes into 2 different bays where there's vacuums and air pressure hoses, but also all the inventory to restock that ambulance using a similar system, speed loading system that's color-coded, can go and restock the ambulance with sealed cabinets. And the idea is to really lean out the processes, right? But it's also it's about reliability and making sure that one time you need the meconium aspirator, that you don't know if it's on the truck or not because you forgot to check, is that reliability piece, and it really helps with that. Same thing with the actual warehouse for us. So we purpose-built our warehouse around the concepts of making speed loaders with a central table surrounded by all the inventory and stock needed to make that specific speed loader. So we can, again, lean out the number of steps. And this is a process I've learned from other EMS agencies, down at Sunstar, amazing systems that they have down there. If you ever have a chance when you're down there, take a look in Fort Worth, EMSA, my old alma mater. Also have great supply and logistics systems, and that utilize many of these concepts. So how many inventory supply locations do you have, and have you been able to downsize those? I think Chief Baker, you mentioned you were able to kind of decrease the number of sites that had to be serviced, right?
Right. For 30 stations, we went down to 5 locations. And so we knew that the fire crews were out going to district chief stations for paperwork, or that we have to do bump tests on CO meters and different meters and things like that are centrally located. So we kind of made regional hubs. And I wanted the ability to get anything at any hour of the day. And so we took 30 stations worth of inventory, pulled it out of the field, and reduced it down to 5. And there was a little pushback, I won't lie to you, but for the most part, we haven't had any real complaints or issues about that. And so folks are using the system. Obviously, I'm getting information that items are coming out and we're restocking. So we were able to really reduce the number that we were trying to maintain. And that's what really contributed to our medication waste and consumable waste.
Great. Dr. Augustine?
Clearly, we're moving up the scale here. And regardless of what systems that we're running out of, the fewer supply logistics centers we are, the better off we are. And then information coming out is all the better. And once again, I will say, going back to the crews, we have to have the information that they need. And distributive education now allows us, when we have to switch something in the supply chain, that they have the information ready to go. So logistics goes down, but the distribution of the education related to the products has to get broader and broader.
Absolutely. I mean, that's one of the things I know as when we converted over to this system. I remember doing this when I was at REMSA in Reno, Nevada, and it was a 2-day, 48-hour nonstop process to basically clean out every ambulance, pull every piece of equipment and every consumable out, and then restock it. And we ended up with this huge pile of all this excess inventory that I think we valued at close to $40,000 or $50,000 worth of inventory that was just sitting out there. But what we found was it's also managing complexity. So the more you have, the less standardized you are, it creates problems, right? And whether that be, again, for muscle memory for the provider, so if they're not in that same ambulance every day, one provider wanted to have something one place, another provider would want to have something another, and then you're sitting there scrambling trying to find, again, that meconium aspirator when you need it. So standardization and the reduction of the number of distribution points eliminated a lot of that complexity and improved reliability in the process in the system, which ultimately I think helps from all the different reasons we talked about. Chief Baker, we touched on this already, but maybe go in a little deeper, what is your replenishment process for remote locations?
Well, simply, we went from this, like I kind of talked about the last question, we went from a distribution system of staff taking it out to every direct point to this regional hub concept, and we stock those locations from the central warehouse about every 2 weeks, and so we know what needs to be pulled out and taken in there. And those are common use items, so there's going to be items like that meconium aspirator that we're not going to put in a vending machine because we don't need to have 15 of them out there, but we'll take those out. And then most of the replenishment is one-for-one exchange with the transport crew. So it kind of works as a system that helps support each other. So.
Yeah, one of the things that we've done is at our organization, we also resupply physician offices with basically first response bags because we're part of a large health system. And so we've created a process very similar using FormStack, which is a cloud-based system that allows you to build forms online for people to go ahead and fill out. And the process basically goes as a bag is expiring or is used, they can go online, click a form, it instantaneously shows up, and then we can go ahead and get them a new bag and do a swap out. And so that's using, again, the idea of using technology to notify, because we don't have the more expensive systems, definitely things we're looking at doing to try to manage this, but there are other ways as well to do some of these things. We also use that technology for doing our inventory at our different locations and our different turnout locations and sites. It's still very labor intensive, it's not automatic, so clearly going to the technology is ultimately going to help us save down the road in labor costs, as well as some of the other things we've talked about. So during times of drug shortages, how are you managing your on-hand inventory in the most efficient way? I know we've chatted a little bit about this, but Dr. Augustine, you want to go deeper?
Yeah, so that you have to, again, go more and more central in terms of the drugs that are short. Deciding, again, oftentimes at the regional level how you can best use the inventories that you have, down to the point, again, where there was only one source of mag sulfate for a while, and that was in an EMS supervisor's vehicle. And anybody who needed it, that's where they needed to go. And that's the level of cooperation we're looking for in certain of these cases. Otherwise, drug by drug, what are the inventory needs? When we have to switch out, that's when it's most difficult for our personnel. And so then this just-in-time education. So we are out of morphine, and then we have 2 alternatives, fentanyl dilaudid. We need pain medicine available in each and every drug box, but supplies are now messed up enough that you have to individualize each drug box. For what was ready to expire, you put it in the site where it's most likely to be used quickly under the same license. But then we had to have just-in-time packaging available so that the medic who pulled something out where they thought there was morphine and it's now fentanyl, what's the dose associated with adults, what's the dose associated with children, color-coded, and have it available. So unique parts to the drug shortage that require unique management and then just-in-time education for the people that have to use it. And they have to be confident. When they go in and need a pain medicine, a nausea medicine, something to stop seizures, there can't be any hesitation on their part, and they can't lack confidence, because if so, they're going to say, never mind, close the drug box up, and we'll transport to the hospital and let them worry about it, which is not good patient care and not what we want our system set up for.
It's not the solution, definitely. So before we jump into Q&A, maybe I'll ask my panelists for last words. Chief Baker?
You don't know what you don't know, and until you know.
I like that one. You don't know what you don't know until you know.
Right.
It's absolutely true.
Yeah, that's exactly. Words of wisdom.
Yeah.
Yeah.
Sean?
It's kind of hard to top, quite honestly.
That is pretty good.
I got another Mike Bakerism, the OST, the odor, supply, or odor, store, and trash. I like that one too. That was pretty interesting. I think with regards to you don't know what you don't know until you know, I think kind of building on that is embracing and using digital solutions to help your workflows be more effective in managing patient needs and care.
Yeah, so the other way of saying that is being unconsciously incompetent versus being consciously incompetent, and there's a difference. So if you don't know what you don't know, you're unconsciously incompetent. If you do know what you don't know and you do nothing about it, you're consciously incompetent. So that'll be my little one I'll throw in there.
Your introduction at this
Not
point,
at all.
so.
Not at all.
I'm worried that what is going on in the drugs world is going to recur in other disposables and in other areas. There's no one as resourceful as EMS people in coming up with solutions, and thank goodness. And again, it's all around good patient care. So we need to distribute our knowledge well enough that we don't interfere with great emergency medical care that people need.
It's probably one of the best things about EMS is adapt and overcome, and I think it's why as we talk about transitioning into EMS 3.0, we really can change the game because we're a mobile workforce, and all of these different things that we're learning to do. I think we can help healthcare learn from, right? Because we've had to learn how to do it better. We've had to learn how to do it faster. We've had to learn how to do it cheaper and adapt and overcome, and we've never been able to really spend our way out of our problems. We've had to think differently out of our problems. And so this is a great example, and also combining that with technology to be able to help us solve our woes. And I think there's, as I've mentioned in other articles and things that I've written, healthcare has a lot to learn from EMS, and I think on this topic there's definitely opportunity. So we're going to open it up to questions. I'm going to raise up the lights and see if there's any questions from the audience.
A.J. Heitman from GEMS. REMSA recently announced a contract with a drone manufacturer to be able to send unpiloted drones geographically to deliver AEDs. What kind of solution do you think that'll have to deliver supplies to rural stations?
I'll see if the panelists want to jump on that first before I comment.
Well, I think that's actually kind of intriguing. So it's the Amazon concept. And if you think about if you take away whoever the supplier is and whoever the needs are, it's really ultimately just aligning a need, aligning a vehicle to get that need satisfied, and aligning the person who requires that. So ultimately, sure, there's a lot of visibility for it. I think there's a lot of, whether it's going to be a UAV or whether it's going to be some other concept. Is that space? Is that uncharted territory? Is it a green field for somebody like Boundary? Is it a green field for someone who hasn't thought about those needs? But I'm pretty confident that if you have 452 square miles for which to service, and a lot of which is dirt, the most effective and cost-effective way, I should say, is to have that could have been delivered from that central warehouse by an example, that UAV.
And imagine just down the street here, if, as that episode began, you send a drone in loaded with tourniquets. There are multiple uses for drones. for knowledge, for distribution of product that is needed. There are a lot of uses for those coming to us.
Yeah, I think there's applicability in a lot of things, AJ, on this issue. I just read an article that Amazon's considering getting into the pharmaceutical business. And so imagine what that's going to mean, right, especially with the drone distribution network, the ability to on demand, within minutes have a medication delivered. Our health system is looking at investments in drone technology, not just for urgent things like AEDs and tourniquet delivery, but also for delivering diagnostic equipment into the patient's home, potentially delivering medications to the patient's home. Again, thinking of that whole EMS 3.0, it actually scares me a little bit because we're just starting, the whole concept of community paramedicine, but yet potentially within 10, 20 years, maybe a little longer, many of the things we do in this community paramedicine world will be replaced by drones, especially as technology shrinks the diagnostic equipment. And as we start to overcome the issues with the drone distribution system, which is really about mapping airspace and making it safe and, making sure that these things don't crash into each other. I mean, believe it or not, the technology's coming. And it's quite, I guess, a utopian future, but it's quite interesting. So I think there's absolute applicability in what we're chatting about. Maybe even consider 20, 30 years from now, we won't carry any inventory in the ambulance, and the drone will just deliver, what's needed based upon, some type of assessment. Who knows, where that might go. Other questions? AJ?
Well, I'm just curious how your systems collect the onesies, twosies. They open up a bag, they don't use all the 4x4s, they open up this, they don't use all the tape. Yep. There's a lot of wasted money there.
There is. That's a great question. I'll speak to our system, and then I'll let the other guys comment. With us, basically, when somebody rips open the cellophane of a speed loader, that's a visual indicator to someone that, hey, there's something missing in that bin. During the ambulance restock or resupply process, that bin's removed. It goes back into a warehouse for replenishment, and then another one that was pre-made is taken right then and there and replaced. We also, in the REMSA system, one of the things we advocated for was recycling. So any prepackaged materials, including when you open up an IV start kit, you get a betadine prep, and you get a Band-Aid, and you get an alcohol prep, and you get a Tegaderm, and sometimes those things aren't used. We would actually take those items, throw it into a recycle bin, and then repackage those and remake those. So again, lowering some of your overall costs. So that's kind of how I've managed it in the systems I've been involved with. How about from the panel?
This is a remarkably complex statement. Ditto. Everything that John just described is exactly how our bins work. The same system is that they're you call them speed loaders. Whatever you call it, it's the same effect, right? So once the cellophane is broken, the container rather is disrupted, the opened container goes into a reprocessing bin, and those are collected by the same individual who drops off the stock, picks back up that recycle, and it gets reprocessed. So we've actually eliminated that excess waste. And we too do the reprocessing, if you will, of spare or excess equipment from prepackaged cases.
Yep. Great.
We have a locker dedicated in the UCAPIT system for just the same system. So they can return to there, and then when we make our rounds, we can pick up, we pull the locker section out.
Mm-hmm. Great. Other questions from the audience? Are there any online questions?
Yes. With respect to using drugs that are out of date, what, if any, legal consequences have arisen either in your systems or you're aware of any throughout the United States? There's a bad result. It's very easy for plaintiff's counsel to say that's the reason there was the bad result, because of an outdated drug. Now, I recognize that drugs can be used for long beyond the date, except for the nitro or maybe aspirin, as you said, but everything else seems to be pretty long-term drugs made up dates by the drug manufacturers. But I'm just curious if you've run into any of those problems, or have you addressed them in any way in your system?
Yes. This is a state regulatory issue, so there are at least 50 of them. And you have to deal with your state pharmacy board or your state EMS board that comes up with the regulation related to use of expired medicines. For hospitals, Joint Commission requires them not to use expired medicines. So there's one central regulatory body with application by CMS in terms of compliance with their regulations. And the biggest violator, of course, is the federal government, which for all of you who are aware of chem packs, you're aware that you have 10-year-old atropine that's in a chem pack that's been in a regulated environment. Each year the federal government goes through, tests the lot, and make sure that the lot still has potency and is not suffering from any breakdown and degradation of the product. And so they extend the expiration date a year at a time, sitting in the chem packs with those drugs well beyond their expiration date. At this point, this is something very clearly that you have to have the regulatory permission to do, so I don't urge anybody to use drugs beyond their expiration date unless it's been approved. As all of us have the responsibility, as we have critical medicines that we don't have available, and one of the potentials is extending the use of expired medicines, that you go through the regulatory process to get that approval. That is an absolute mandate at this time.
Good question. Larry.
I know one of you mentioned the CAPEX system and the operative IQ system. What's the capital outlay for those types of products roughly, and how have you funded those systems?
Yeah, so the question was, what does some of this technology cost to implement? So I'll turn to the panel who have actually gone and done this.
So I'm not going to quote any prices, but it's not inexpensive. But what I found was that I made the use case up front, and then really started looking for the financing, and it came from an unusual place, which was my city. My municipal government wanted a lean process improvement, and they were willing to fund it. And once we got the word out, talked to the right folks, and told them of this and how we were going to shrink inventory through the areas within our potential for waste, they were like, we'll buy it, no problem. And we've been able to demonstrate the return on their investment pretty quickly.
With the operative IQ piece, I'm going to characterize it as a de minimis investment. Not that it's as inexpensive as nothing, but the time, energy, effort, and overall spend that you'll save, the reduction in spend, if you will, far exceeds any of the cost for the software licensure. It is cloud-based. It's well maintained by Operative IQ themselves. And it's a great logistic and supply management system.
Right, and as I mentioned earlier, Larry, too, there are, I can't speak on behalf of Boundtree, but some of the approaches that I've taken were to, have them build it into the price of the capital, when, build that into the supply costs somehow. So, there are ways to overcome that. And again, I would encourage you to think outside of the box on the financing side of this and work with the vendors to see. But it's clear that there's absolutely an ROI, for it. The ROI is the ROI associated with the savings on the actual supplies is probably going to be smaller than the potential impact for labor, and depending on how you restock. If you're a larger system, you have supply technicians and resupply groups, or anyone that's having to make resupply time, or if it's your supervisors doing it, how much of your supervisor's time is spent managing this, right, and could be freed up to go do something else, like actually supervise. It's those kinds of administrative burdens, and you have to weigh those into your ROI calculations when you're looking at the investment. So, other questions? Mark.
Jonathan, I just want to make a comment from Sunstar with the comment about the logistics manager making their way up the ladder, and I just want to say that's exactly true. Normally what we do in this business is we take a paramedic or EMT and make them in charge of it. Sometimes they're work comp or whatever it is. And we've went a different direction. Our warehouse manager is from Best Buy and in logistics, and our materials area is from Target distribution centers. And of course, they're very knowledgeable in distribution, RFI, and just one of those things that we've always kind of promoted up, which we all want to do. But the folks who really know what you're speaking of, and the comment that the logistics managers made its way up is very true.
Yeah, we were having a discussion at the Education Committee yesterday about, EMS is a series of businesses within a business, right? And so, to Mark's point, when we promote a paramedic up and then expect that they understand supply chain management is doing a disservice to our people. And so, as you get bigger, as you go to scale, one of the things you need to understand is you run these different businesses. You run a call center, you run an ambulance service, you run a resupply system and logistics in a warehouse system, you run a fleet maintenance system, you run a training program, you run a quality system, right? All of these things require different levels of expertise. One of the beauties, I guess, of this technology is it helps to fill some of those voids or fill some of those gaps if it's used correctly. Especially the electronic systems can help. It's a great tool, but it can also be used to help fill some of those voids if you can't afford the supplier logistics person from Amazon to come run your ambulance service. The technology is going to be a nice gap filler for you. Other questions? Okay. I think we're running short on time, so I just want to say thank you very much. Hopefully you've all become consciously competent, meaning you've learned something, and now you're going to go do something about it from this session, and I'm going to turn it back over to Sarah from GEMS. Thank you.
Thank you to all of you for attending and for your great questions, and to our fantastic panel. We appreciate it. We also got a lot of really great questions online, which we'll be looking at and answering at a later time. We just simply didn't have time to respond to all of them. I just wanted to say thank you again to Boundary Medical for sponsoring this and for their support in making this opportunity available to all of you. And for those of you who are listening online, don't forget that this presentation will be archived on gems.com/webcasts within 48 hours so that you can share it with your colleagues. So thank you so much again to all of you for attending and to our great panel. We'll see you back for another webcast and panel soon.